Okay, our final speaker until our break will be Dr. Jeremy Franklin, who is a native of Utah but grew up in Ames in Iowa. He went back to Utah State where he received his bachelor's degree. He completed medical school at Penn State University and then did his emergency medicine residency at the University of Arizona. During residency, he was an active instructor in both advanced trauma life support and also in advanced hazmat life support. While at the University of Arizona, he was also involved with a variety of researching devices and methods of video-assisted direct laryngoscopy for intubation. His professional interests include advanced airway, disaster medicine, backcountry medicine, and ethical issues. As you can see from some of his interests in medicine, he also has a lot of interest in just about every activity that you can do outdoors. So it's our pleasure to introduce Dr. Franklin, who will be speaking on ethical issues during emergencies.
All right, thank you for that introduction. It's the last morning lecture. Everybody's breakfast burritos are sitting heavy. So I'll ask you to do some jumping jacks with me. Also, as similar to Dr. Affleck, this is my first conference. I'm honored to be presenting here this morning. My hope is that you're able to find some information here that will be useful in your practice. And I think some of this stuff is actually very interesting. I know this is a time this morning that's dedicated towards the focus in what's new in my specialty. And I entitled the discussion this morning, Medicine Ethical Issues, because I feel this crosses specialty boundaries. I think there are aspects of this discussion that can be applied to many of our practices. Okay, so why did I get interested in this particular topic? At Penn State, they actually had one of the first ethical programs in the country. I believe it was the first for medical students, and it was required to go through that. Maybe some of you have met Dr. Ken Iserson. I know some of our great residents here. Have any of you guys used that manual, How to Get into Residency, by chance? Seeing some nods of heads. That book was authored by Ken Iserson. He's a really enigmatic guy, involved in many different things. He's sat on national ethical boards. He's heavily involved in backcountry medicine. And he asked me one day if I was interested in writing a paper and assisting him with writing a paper. And I said, sure, why not? Let's give it a shot. It was a good experience, and that's where some of the stuff came from. So briefly, objectives today, I'd like to briefly talk about what ethics are. Specifically, the crux of the topic today is family attendance at code resuscitations and painful procedures. Also emphasize the importance of considering these topics ahead of time, and then obviously hoping that you guys will be able to glean a pearl that might be useful in your clinical practice. So just briefly, ethics. They're a set of societal and professional norms. They encompass and affect our behaviors, oftentimes subconsciously. I think sometimes when we think about the stuff that we're doing, it's surprising the number of things that we just go about just doing. Bioethics is really more focused on the actions we take based on medicine's moral code, and that's the sort of sine qua non for the right thing to do. So dilemmas, and this talk really isn't about ethical dilemmas, but they really present when among the choices none appear to be acceptable, clear, or better than the others. And then lastly, one of Ken's big things that he was always saying is failing to act is making a choice by default. So for me, it always, with most topics, I kind of question myself in terms of how is this pertinent to my practice, and how can I clinically integrate this? So the key, I think, is to become familiar with ethical issues, reasons behind acceptable decisions. I think many of these issues affect our daily practice. They certainly affect my daily practice in emergency medicine. And they better equip physicians to make the best choice possible for our patients. So I'd like to go through a little case here. This is actually a case that I had as a resident in Tucson at the University of Arizona. It was a rather sad and sudden case. A 6-year-old male came in. He was in medical code arrest. He was found by his mother in his bed about 10 till 8. He was unresponsive. He was apneic. He had had a TNA the day before. The patient, according to the mom, was last seen normal at around 4 in the morning. He had been given some hydrocodone for his pain. And the thing I want to propose is, as the mom's being taken out of the trauma bay to the family room and is looking back into the trauma bay, what are your thoughts? What do you do? So let's get into this, a family attendance at code and procedures. I think this really has application broad-based. It can touch pediatric, adult trauma resuscitations. It can cross neonatal, pediatric, adult resuscitations in an inpatient and ICU setting. And certainly it can be involved with invasive procedures that we do. Really, traditionally, medical attitudes, and I've seen this also in the ER since I've been in the specialty, have been for decades not to permit and allow family presence during these code resuscitations. The exception to that is definitely EMS resuscitations at home. And as I was discussing actually this yesterday with one of my good friends, Dr. Bailey from up in Logan, he mentioned maybe this is sort of like the fathers not being allowed to be in the delivery of their children. I remember when I was had the opportunity to go into my delivery of my first child, my dad said, "You're lucky, because I never was able to go." They said, "There's the door, sir, and have at it." And it just made me think a little bit that who knows, maybe in the next 5 to 10 years there'll be a little bit of a turning of the tide. So really, this is starting to become more and more, I guess, pervasive in the literature. This is one of our major publications called ACEP News out of our College of Physicians. And this was actually in last year's, and forgive my chicken scratches because I kind of marked it up prior to when I was going to be putting this into my talk. And I think some of the stuff was pretty interesting. It was based out of a study that they had done that shown that families had done really well, especially if it was an organized effort. I tend to like this quote that says, "We don't give families enough credit. They'll typically do everything you ask them to do. They understand it's a privilege." And in the bottom right, just another blurb that said, in the study of the family members present during resuscitation said they would repeat the experience, whereas family members not present said they would have preferred to have been present. So in the ED, family is usually taken back to a kind of a social gathering area, a family area. We have a small area at McKD where families are taken to during these code resuscitations. During some procedures, not all, and not all institutions are families asked to leave during procedures, but for the most part, most procedures, I would say family are asked to leave, and I'd also be interested to see what your guys' experience is with this. Certainly very painful, invasive procedures. In my training, I've seen most of the time family is not present, but not all the time. That's certainly true. And while no uniform standard is really present, I would say more and more physicians, practitioners, nurses, hospitals are allowing family presence. An increasing number of organizations support family attendance. The study and literature tend to support it during end-of-life resuscitations, during procedures, as mentioned. Some of the large endorsements, I would say, are by AAP, also the APA, Ambulatory Pediatric Association, and probably the largest endorsement comes by AHA, the American Heart Association, really based on the benefit that they perceive and the lack of harmful effects. Family attendance can be, I would say, mutually beneficial, saying that both to the medical team and to the medical provider and also to the family. Family members who are present express that they would do so again, similar to the study that was there in the ACEP News. Their presence had helped their loved one, and it had also assisted in their grieving and coping process. I thought this was kind of interesting in looking at some of the psychiatric and psychoanalytical literature that they had exhibited less anxiety, depression compared to those families who were absent. Members were able to view and appreciate the effort, organization, and skill involved, and I think that's something we certainly see in the ER. I can remember just recently working a shift where we had actually 3 very critical ill patients come in. And it's really amazing to watch in the ER how the staff descends down into these areas, and it consumes such a large amount of our manpower, nurses, technicians, physicians, everybody. I would describe it as organized chaos. And certainly there's definitely a large amount of organization and skill involved in these resuscitations. I think there's a very big sense of being included rather than being excluded. And my feeling is that I think that really strengthens the relationship with the family. That's been my limited experience. And then also finally, family members are able to see that we're attempting to do everything is trying to be done. And this does provide a sense of closure, I think, for the family. So family members really rarely ask if they can be present. Given the opportunity, many, but not all, will opt to be there. As healthcare providers, it's really more our responsibility to ask, when possible, of their wishes regarding resuscitation presence. And really, the attendance of this process, and I won't go into the huge meat with regards to this, but it really is more of a coordination process and protocol-driven from the entire healthcare team. Physicians are involved, nurses are involved. If you have chaplains or social workers or technicians in your area of practice, they're also keyed in and they're included. So one of the leading children's hospitals in the country, as many of you know, and especially with regards to ethical and kind of leading edge, cutting edge technology, is Children's Hospital Philadelphia. It's actually known as CHOP. And one of they started to really institute this protocol and have had really good luck with it. Resuscitative team members are made aware of family presence, and then really the key is that in a setting that's away from where the action is, I guess, taking place, social workers and or chaplains, they're assigned to really screen the families, screen their interests, and then also probe and see what they're going to be seeing, and also explaining to them the situation that will be involved. They accompany the family. They are available to address concerns. Family presence certainly should not compromise or change the medical decision-making of the resuscitation, and has the potential to increase professionalism among the resuscitation team members. So some of the concerns and obstacles, and these are all extremely valid and pertinent to clinical practice. Will this interfere with the process? Will it slow down the resuscitation? A concern that I had is, and still have, in terms of, is there going to be too much verbalization? Oftentimes decisions have to be made fairly quickly. The patient's obviously critically ill. Is there going to be too much discussion, too much talking, too many questions? Will there be detrimental effects on the family? Will it increase medical legal risk? These are some questions. In closure, I wanted to provide a few studies that address this. These are from large journals, and they're fairly recent. This is out of Pediatrics in 2007. This study is actually out of the Children's Hospital Philadelphia, CHOP. And it was really, the goal was to evaluate outcomes of a structured program of family presence during pediatric trauma team activations. And really the 3 endpoints were need for termination of family presence, in other words, asking the family to leave the room. 2, times to completion of key parts of the evaluation. And then 3, really the opinions of the staff right after the conclusion. What did the staff think? How did it go? Would they do it again? What were the problems and the pluses? So this one, 197 family members participated in family presence. There was no reported cases of interference with medical care by family members. 7 were asked to leave for various reasons that the authors really didn't go into. Times to completion of key components of the trauma evaluation did not really differ significantly. Surveys were completed in 136 out of those 197, so pretty good return rate. And the majority of providers reported that family presence either had no effect on or improved medical decision making, and that was a really large percent, 97%. Institution of patient care, 94%, and communication among providers, 92%. And I really like the last one, communication with family members, 98%. So very, very high numbers. Conclusions, suggest that there's an overall low prevalence of negative outcomes associated with family presence. These were during pediatric team evaluations after implementation of a structured program. And excluding family members as a routine because of provider concerns about negative impact in clinical care did not seem to be indicated in this study. Next one, this one's out of Texas Children's Hospital in Houston. It's a pediatric intensive care unit. And should family members be present during interventions in an ICU? This question is a source of debate among healthcare providers. We propose to define perceptions and practice regarding family member presence. Again, this is pediatric intensive care. This is out of the Journal of Pediatrics in 2007. There's a lot on the slide, but I wanted to leave on here because I felt that there were some important aspects of this. So there's 211 surveys that were completed. Of all responders, the majority believe that family members have a right to be present during resuscitations, about 3/4. Team rounds at 77%, and invasive procedures lower at 57%. The majority of respondents encounter families that rarely request to be present during invasive procedures and cardiopulmonary resuscitation. Again, reiterating what I had mentioned prior. Many providers practice in ICUs where family member presence is allowed. 64% allow family members to attend team rounds, and we've certainly seen that. Some of the concerns providers have regarding family member presence include family member presence causing stress to the provider during procedures, distractions, nervousness among the team during resuscitations, and the majority of providers predict family member presence during cardiopulmonary resuscitation would not increase medical legal concerns. And I would say I would agree with that for the most part. I think that in my limited experience when I've had discussions with families, because it strengthens the physician-family relationship, I think that's a good thing. And then lastly, this one's actually out of the University of Utah, and I kind of like this one. This is fairly recent, 2009. It's looked at family presence has a broad professional organization support, is gaining acceptance. We seek to determine whether family presence prolonged the resuscitations as measured from time from the ER to CT scan and then the completion of the resuscitation. And the reason I thought this was kind of interesting, because it said, this is a large number of trauma activations. We're looking at close to 1,300 here. 700 patients were included in the study, 283 with family presence on even days, and 422 without family presence on odd days. So I was looking at that, I'm like, I guess don't have your trauma and your MVC on an odd day. So 283 compared to 422. Median time to CT scan and median resuscitation times were similar. With and without family presence, there was really no clinically relevant difference in CT or resuscitation time. And families believed that their presence was helpful both to their child and also to themselves, with the conclusion that they felt that it did not negatively impact the resuscitation. So in closure, on the case that we had, so this child was resuscitated for about 40 minutes in the trauma bay. The child had intermittent pulses. The child went into PEA. I remember went into VTAC. Finally, sinus was gained. The mother was present throughout this process. Family arrived into the ED. Were really able to see the patient. The patient subsequently was transferred up to the PICU. And we had a very good PICU team. Family members kind of descended upon the ICU. His clinical status continued to decline, and collectively, up in the PICU, care was withdrawn. So, in summary, I think considering some of these issues in advance is healthy. Considering family presence, possibly in some of your practices, see how it would work, and hopefully college football is around the corner soon. Okay. Any questions, comments? I'd love to hear what your guys' thoughts are and any experience in this. Yeah, please. Thank you. Yeah, please. Those are good points, and I think part of it depends on, at Arizona, we were just starting to implement this as I was leaving, and it has to be a structured process. It really can't be people are coming and going willy-nilly. In terms of limiting, I think limiting it is important, yes. Large numbers I would see would not really work particularly well, especially in cramped quarters, depending on where your resuscitations are. The staffing involved is also important because the social workers and chaplains, depending on what services you have, they're really assigned to the people. They screen their interests, and then they're also explaining to them the situation that they might see, i.e., there might be a breathing tube placed. There may be invasive lines. There may be chest compressions. Okay, these are things that they're explaining to them. And my feeling on it is that once you've assigned the social workers or technicians or chaplains to those individuals, those resources are being used up. So I think it might be difficult to continue to bring family members in that haven't kind of gone through that process. So I think yes, it'd need to be limited. Rob, does that answer your question?
I have a comment.
I can't see you.
I'm over here.
Okay.
Right here.
Yeah, please.
We've been doing this for 7 years in our department, and we've found it very helpful, not only for the patients and the parents, but more importantly for us as doctors, because during the resuscitating process, there are times when I find that there is something that I need to ask the family about, or could this have happened, or information that I can get instantaneously. We limit our people to 2 people to come back. We give them the option. We do so with spinal taps. We do so with other procedures. If they want to be there, they can. If they don't have to be. We do have a social worker there with them. But the majority of people want to be there. And we've found it to be a very successful and successful for, we think, the family, but especially successful for us because we feel like that we've had interaction with the family. And because that's where our major focus is in so many of our resuscitative efforts, it has to be on the family. The patient, 5% survive in resuscitative efforts. And so I think we established that very early on, and that's where our focus should be.
Awesome. Where was that at? Excuse me?
This is American Fork.
Okay, American Fork. Awesome. Thank you.
I would just comment that I was in a situation personally with my family and the loss of a daughter, and found it very helpful to be there. I'm curious if you're aware of any case law and how that affects actually the rights of family to be there if they insist.
That's a great question. Actually, I'm not aware of case law. I know that in Arizona it was available upon certain screening process to be able to be there, but that's a good question. Do you by chance know of any? I don't. Okay. That's a good question though. Okay, yeah, please. When I was looking at the literature, it was more people's presumption that it would decrease medical legal risk, but I'm not sure if there was specific data to focus on that. And I think that's also a very good and valid question. Is there literature to support that? And I think this is really coming through the pipes. I think more and more of this literature is still coming, and that's something to keep an eye on. But that's also a valid point. Yeah, please. Right. No, that's a good question. The feeling I got by looking at the literature and was that there certainly was more closure involved, and that people had, as mentioned, decreased depression and anxiety rates after the events. You're specifically asking about significant invasive procedures, maybe a chest tube, maybe cracking a chest in a trauma resuscitation. That's a very valid question. Did not see specific points in terms of PTSD. The depression anxiety rates from some of the literature seem to be a little bit less.
And I'm sort of asking, have the questionnaires been the same kind of questions you're asking when you're trying to identify a post-traumatic stress syndrome? Or perhaps so, I don't know.
Right, and I'm not sure if I know either. That's a good question. Okay, thanks for having me, guys.
Okay, we'll go ahead and we'll break until just a few minutes before 10 o'clock, at what time we'll then reconvene in ballroom B&E.